Welcome to the Healthful Woman podcast. Today is Thursday, July 2nd, 2020. Today's podcast is the second in our four-part miniseries on prenatal genetics. Our first podcast was Monday, which was an introduction to prenatal genetics. In today's podcast, looking into our baby's genes, aneuploidy screening and testing, Dr. Tamar Goldwaser and I discussed the topic of screening pregnancies for genetic abnormalities in the fetus. We discuss advanced maternal age, the nuchal ultrasound, non-invasive screening, and invasive testing. This is a complex topic with a long history, and it often generates a lot of confusion. Hopefully, you'll find it both interesting and informative. Next week, look forward to two more podcasts in our Prenatal Genetics miniseries. Hope you have a great July 4th weekend and have a great day. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. All right, we're here again with Dr. Tamar Goldwaser, OBGYN and medical geneticist, and we're going to talk today about aneuploidy screening. Tamar, welcome to Healthful Woman.
Thanks for having me again.
Just so everyone understands what we're talking about, what exactly is aneuploidy?
Aneuploidy means that a human being or another person has a different number of chromosomes than what you would have expected. We expect that humans have 46 chromosomes. They get 23 from their mother, 23 from their father. And aneuploidy is any time you have a different number other than 46. So either you have an extra chromosome, or you're missing a chromosome, or you have an extra piece of chromosome that's big enough to count as an extra chromosome.
When you refer to 46 chromosomes, you mean in every cell of our body?
In every cell of our body.
Right. And so, we refer to it as aneuploidy screening. I think colloquially, most people talk about Down syndrome screening because Down syndrome is the most famous, so to speak, of the aneuploidies, where there's an extra 21st chromosome. So, when we say aneuploidy screening, a lot of patients are thinking simply Down syndrome screening, but we're screening for much more than just Down syndrome when we do this type of screening.
Yeah. So when someone comes and they're pregnant and they say, I want to be sure that, or I want to check to see if the baby has Down syndrome, the way that I understand it is they want to know, does the baby have a serious genetic abnormality or a genetic problem? And so, so hence aneuploidy screening, checking to see if there's an extra chromosome or if there's a missing chromosome.
Right. And I think that's such an important distinction that you made is, there's so much to try to understand when doing this screening. So for example, we talk about Down syndrome, but again, Down syndrome is a condition and a lot of people don't want to screen their babies or their fetuses for Down syndrome because for them, sort of, that's great. And the baby's born and the baby does or does not have Down syndrome. And we're going to love him and her and raise him or her. And we don't need to know any of this stuff till after birth. And that's perfectly fine. Like, that's great. Other people, they want to do testing before the baby's born just so they know, right? Just so they understand and they can, prepare and just understand what's going to happen and maybe have a plan in place. And other people are just thinking sort of more broadly, not Down syndrome, but just in general, is my baby going to be healthy? Are there going to be conditions that are related to genetics? And there's so much about that. And it's really important to have a conversation with a patient to understand what exactly are we trying to do here when we do this screening or this testing so that what we do is aligned with what the patient wants.
What you described is pre-test counseling. So that's so important, right? So a patient comes and says, I want to check for Down syndrome. It's worth a minute or two of a conversation, sometimes longer, to find out what are we looking for, what are our goals in this test.
How would you approach that conversation? Like, what kind of goals might people have?
I would say most people say, I want to be sure the baby is going to be healthy. And so I'll say, okay, well, there are certain tests that are available. There are actually a lot of tests that are available while you're pregnant that can screen for certain conditions. And even if you go all the way, let's say, and check for as many conditions that are available, we always take a step back and remind ourselves that there's no such thing as the perfect baby. There's no such thing as 100%. And we have to go into this testing knowing that we're just checking for what we can check for. And then in the end, we always know having a baby is taking a risk, and you know that things can come up as people develop, as children develop. We can't always be prepared for everything in advance. So for those who want to know it all, that's my counseling. We can test for what we can look for, and then we have to just, accept whatever else comes our way. And then there are patients who say, well, there's my cousin has Down syndrome, and I want to know if my baby's going to have Down syndrome. And so then that's a very targeted question, and we can go on and investigate that for them. And some people really don't know what they're actually asking. They're just worried that the baby should be healthy. And those patients, you have to then break it down and say, well, we can do a test to check for some things. Are you interested in knowing? Are you the type of person who will feel better with some of this information, or does testing make you feel anxious? And let's think about how this may play out in various ways. Different people need different levels of guidance.
Right. And it's hard because there's a lot of complexities that come into this conversation. For example, for some people, it starts bringing up the idea of, would I have an abortion? Would I end a pregnancy if a baby had a certain condition? And people don't want to think about that. I mean, it's pretty gruesome to start thinking about what would it require for me to end a pregnancy that I wanted. And it's a very difficult conversation in general, right? And it's obviously
Hmm.
very heated conversation for a lot of people, and people have very strong feelings about that one way or another. That's number one. Number two, a lot of people don't exactly understand what we can and can't test for. And then there's also issues of how accurate are certain things, meaning, again, and we'll talk about screening tests versus tests that actually give you a diagnosis. And also, what does a normal test, quote unquote, mean? I mean, what do we actually learn? So let's say you do a test and say, okay, I'm really confident, or I know 100% your baby does not have Down syndrome. And like you said, that doesn't mean the baby's going to be healthy. It just means the baby won't have Down syndrome. There's a ton of things, unfortunately, people can have and be born with, and we can test for, a number of them, but not all of them. And so people say, does this mean my baby won't have autism? And I'd say, well, no, like we can't even test a newborn to see if he or she is or is going to have autism. So you can't test a newborn for it. You certainly can't test a fetus for it. And there's a lot of, as you said, pre-test counseling that has to go into place so everyone understands exactly what are we doing here? Like, why are we doing this? And I think that doesn't happen a lot. I think a lot of people just walk in, they said, oh, yeah, my doctor did some genetic blood test and said everything was fine. And you're like, well, that
Yeah.
can mean so many different things, And it's
Yeah.
like, oh, okay, good.
Agreed.
You know,
You brought up so many things. So I agree that, well, I think in the practice of OBGYN, there's just so much to be done in the first few appointments that the testing for Down syndrome, let's say, is just one of the things. So I think that the conversation doesn't go as in depth as we're talking about right now. I think the important thing there is that people should just know that genetic counselors are out there, medical geneticists are out there, and if the conversation needs to go in that direction, they should just phone a friend. I will sometimes ask people point blank, if you find out that the baby has a certain condition, do you think you might think about terminating the pregnancy? And it's usually people are not prepared to be asked that question, but will sit in a quiet room and they'll sit with their thoughts. And sometimes there's no answer available right away. Sometimes there's an answer right away. And if the answer is yes, I don't think my lifestyle or my family can handle something like this right now, then I'll reflect back to the person, okay, so your answer tells me that you want information and that it would be important to you. So that would push us a little in the direction of testing. Whereas if someone knee jerk reaction is definitely not, I would never consider ending a pregnancy, then we open the door to saying, well, maybe we should just not go so far and not do all this testing that might just bring you anguish or that may upset you during your pregnancy. But those patients also may decide that they do want the information because they may make a choice on which school district they're going to buy a house in or which hospital they're going to deliver at. So it's not really about whether to keep or not continue a pregnancy. It's a lot. Genetic testing and genetic information can help families make great decisions about where they're going to lead their life, what schools, what what cities are going to give us better access to services if they're going to need services down the road. So yeah, you got to get to know your patient before you know which is the best test to recommend for them.
Right. That's such an important point because so many people think it's sort of this all or none, meaning, well, since I would, consider ending a pregnancy, I want to test for everything. Whereas someone else, I would not consider ending a pregnancy. I want to test for nothing. And that's fine if that's sort of the conclusion that people get to. But there's other reasons to have information and knowledge aside from just ending a pregnancy. Like you said, it could be just sort of a family situation. It could be potentially, does this baby need to be born in a place with more medical services, or do some of these conditions require treatment early after birth? And also sometimes after birth, making a diagnosis is complicated because it takes weeks and you have to, all these visits, and there's so much else going on. So there's a lot of reasons someone might do it. And so there is definitely a range of what people want. Sort of the least aggressive way is to not do any screening and just say, okay, my baby's my baby, and I'm not going to go down this road and do genetic, screening or testing, and that's fine. On the other end of that scale is what we call invasive testing, like a CVS or an amniocentesis, and we'll talk about that. And that's really like a diagnosis. That's like actually testing the baby, like really not different from, doing a blood test or a cheek swab of the newborn. That's sort of the level of information you're going to get. And then in between, which is where people get confused, is all these options and paradigms and algorithms for screening, which is not doing nothing, but it's not doing invasive testing like with a needle. It's doing either a blood test or ultrasound, or sort of taking a history and saying, okay, where do you fall in the risk spectrum? And then maybe if you are more higher risk, you'll do invasive testing. And if you're more lower risk, you won't do testing.
So I do spend some time explaining to people what a screening test is. And so back in the day, if a patient would walk in and say, what are my chances to have a baby with a chromosome problem? We would just use their age and say, okay, for someone your age, this is your risk to have a baby with aneuploidy, which is, not 46 chromosomes for a human, or this is your risk for Down syndrome. And now you can do a screening test, which will take in more information, take into account more information that's unique to you and your specific pregnancy that you're carrying. And that'll give us a better prediction about your chances for having a baby with a chromosome problem. That this fetus, that the one that you're carrying, has not 46 chromosomes, but something else. So
Right.
some tests will take into account an ultrasound measurement of the nuchal translucency, which is the thickness of fluid at the back of the baby's neck, or a blood test that will measure certain proteins and hormones that are currently circulating in the woman's bloodstream that come from her pregnancy, and also her age and her ethnicity and her weight and her whether or not she has diabetes, and they can calculate a more specific prediction. Okay, here are your chances for this baby in this time in this pregnancy to have a chromosome problem. So it's still just a prediction. It's not a diagnosis because you haven't actually tested the pregnancy directly. And then it gives a woman a better sense. Okay, am I in the higher risk category or am I in the lower risk category? And sometimes that's useful for doctors and patients to decide, should I go further and do invasive testing, or can I feel comfortable leaving things as is?
Right. And there's two really, really important points that you made there that I want to highlight. And the first is that, in terms of age, it is well known, and it has been well known for a very long time, that as women get older, the risk of aneuploidy, the risk of having a baby with one of these chromosomal abnormalities, increases. So the risk for a 30-year-old is higher than for a 20-year-old, and the risk for a 40-year-old is higher than for a 30-year-old. And there was this classic cutoff at age 35, where if you were over 35, doctors would say, okay, you're old enough that your risk is high enough that you need, that was a term that was used, you need an amniocentesis or a CVS to find out. And if you're 34 years, 11 months, and 31 days or younger, you don't need it. You're perfectly fine. And that was the reason 35 was picked, is only because of sort of what was the actual risk at age 35, about 1 in 200, and what was the risk of the procedure itself, about 1 in 200. And so the thought was if you're over 35, the risk of having a baby with Down syndrome is higher than the risk of the procedure. And if you're under 35, the risk of having a baby with Down syndrome is lower than the risk of the procedure. So that's why it was picked. Nothing actually happens at age 35. Nothing magically increases. The risk steadily goes up. And so what you're saying is that originally, when we had no other way to screen, doctors would just say, okay, we'll use your age because that's what we know. But now that we have other options, with ultrasound or blood tests, we can do more screening. And the other thing that you mentioned, which is so important, is that these types of genetic conditions, aneuploidy, an extra chromosome, a missing chromosome, Down syndrome, almost always have nothing to do with the genetics of the parents, meaning it's not passed down from parent to child. These are new. And so each pregnancy it has to be redone because each baby has its own risk based on that particular pregnancy. So you can't say, oh, last time I was low risk, so this time I'm also low risk. Well, no, I mean, each baby has its own risk. And so these things about checking the ultrasound features of this particular baby or the blood hormone levels during this particular pregnancy will give a risk for just this pregnancy, but not other pregnancies. The only thing that sort of carries is the age of the mother. Essentially, everything else is unique to that pregnancy.
Yeah, agreed. And just to add, I've heard many patients say, well, there's no Down syndrome in my family. I don't think I'm at risk to have a baby with Down syndrome. And that's something that we have to teach our patients that it's not something that runs in a family in general. The vast majority of cases of Down syndrome are new to that particular family because it's something usually that happens by chance.
There are other genetic conditions which are almost always passed from parent to child and run in families. And that's a different type of conditions, different type of screening process we'll talk about. But for aneuploidy, it's not something that runs in families. And so again, people may not want to know this information, but if they do, they can't rely on their family history to tell them what is their risk of having a baby with Down syndrome or any other aneuploidy. And so when people they're pregnant and they want to they want to do these sorts of screening tests, as you said, there are several options, and there isn't sort of a right or wrong way to do this because there's several tests, and the more tests you do, you can sort of become you're more likely to pick something up, but you're also more likely to get what's called a false positive, meaning a false scare. And so it's sort of a balance between doing enough screening tests that you don't miss a case of Down syndrome, but not too many screening tests that everybody is told that they're high risk. And how to make those choices are very complicated from a statistical standpoint. But basically what it boils down to nowadays is there's an ultrasound that can be done in 12 weeks called the nuchal translucency. You can do that with or without blood testing, these serum hormones. And that was used for a very long time. And the results that you get, as you said, don't say your baby does or doesn't have Down syndrome. It gives you a number, right? Your risk is 1 in something, 1 in 100, 1 in 1,000, 1 in 5,000, 1 in 10,000. And based on that number, you can decide whether that number is scary enough to you that you want to move on to the next step, which would be invasive testing. Tell us about that and how that screening process works or worked for you in practice. And then we'll get on to the next phase, that NIPT test, which is newer.
I almost feel bad when I present all of the options to a patient because it's overwhelming and there are so many options. Even if you're just looking to do a screening test for aneuploidy, there are a lot of options out there, and sometimes there are a lot of options out there, but your doctor's office only offers one of those options. It kind of helps because then you don't really have to consider all the different options. But the test that I would think most people in this country are still doing is an ultrasound measurement of the nuchal translucency, and you can do your blood work either a few days before or on the same day, and then you'll get a result that actually will show you this was your risk to have a baby with Down syndrome before you did the test. And now here's your risk that this baby has Down syndrome now that you've done the test. And it'll hopefully be a lower percentage. And now your risk has been reduced based on the test. And the common tests that are out there will also give you a prediction on the chances of the baby to have an extra chromosome 18, which causes a much more severe genetic condition, usually actually lethal, but those babies can actually make it to the end of pregnancy and be born alive. So you'll also get that prediction. Here was your risk to have a baby with an extra chromosome 18 before you did the test, and now here's your risk after you've done the test. And so usually that's very reassuring to patients because most of the time they get good results. And I just want to stop and say what I tell patients is I continue on and love my job because most of the time, most babies are born healthy. And so we talk about these really scary conditions and these testing options are offered to every single patient, but the vast majority of the time we're just giving out good news, which makes it very happy and joyful. So it's generally not so heavy, but we do talk about pretty serious conditions.
Right. And even when these screening tests come back, quote unquote, abnormal, and we're giving, so to speak, bad news, which is about 5% of the time, even in that situation, if you move on to the next step, most of the results will end up being normal. Meaning, again, this is a screening test. If you're looking for something that is going to only be present in maybe 1% of the patients, 1 out of 100. And you screen all 100 and 5 come back as higher risk. Again, only 1 in those 5 will actually have a baby with the condition. So what you did is instead of doing an invasive test on 100 people, you're now only going to do it on 5, meaning you're going to scare 5 instead of scaring 100. You're going to scare 5. 4 of them will get normal tests and be relieved and they're done. And then the 1 person you'll pick up. And so even in the setting of these quote unquote abnormal screening tests, many, if not most, will still have normal results on the next step of testing. Like if you have an abnormal mammogram, it's going to scare you, obviously. But then if you go on and do the next step, which would be a biopsy, and find out you do not have cancer, okay. So, I mean, the alternative is every single person just gets biopsies all the time to find out if they have cancer. So you have to do the screening test first to find out who needs that sort of more invasive, more painful potentially secondary test. And so you can sort of narrow it down to just a handful of people so you don't have to do that on everybody.
That was very well explained.
Oh, thank you. And so we were doing this, and then several years ago, a new testing technology was sort of created and refined and brought to the market, and that is testing for the DNA directly in the mom's blood. So, can you explain exactly what that is and how that works?
The testing is also a screening test that you might be offered at your doctor's office, and some people call it NIPT, which stands for non-invasive prenatal testing. Some people call it NIPS or NIPS, non-invasive prenatal screening, or actually it can be called cell-free DNA testing, which is actually describing what it is. So when you're pregnant, the placenta, which in theory is made of the same DNA as the fetus, it's constantly shedding or leaking a little bit of sort of broken down DNA into the mother's bloodstream. And generally, we think of DNA as packaged up inside cells, but this is DNA that's free floating, chopped up, and it's floating in the mother's blood. So once the lab has figured out how to find these DNA fragments in the mother's blood, they can actually say, well, how many DNA fragments represent chromosome 21 from this baby? How many fragments come from chromosome 18? How many fragments come from chromosome 13 and X and Y? And so they'll give us a prediction and say, okay, we saw an expected dosage of DNA fragments from chromosomes 21, 18, 13, X and Y, or two X's if it's a girl. And we're expecting that the chances of an abnormality in the dosage or the number of these chromosomes is expected to be very low. And it's currently the best screening test, the best way to predict abnormalities in chromosomes 21, 13, 18, X and Y.
Right. So it's highly accurate, meaning so we draw sample blood from the mother's arm, and then the lab sifts through this blood and sort of finds the fetal DNA. And based on there's different technologies, but like you said, based on the amount of the DNA, the lab will come back and say, okay, this pattern is a very low risk for having a baby with Down syndrome, or this pattern is a very high risk for having a baby with Down syndrome. And that blood test is the most reliable screen. As you said, it's not diagnostic, it just tells you about chances than anything else. And it's also the one that, since it can do X chromosomes, Y chromosomes, it can predict whether the baby going to be a boy or a girl. And it's also highly accurate. It's like 99% plus accurate, which is really good. And so this test is available. And a lot of people just think of it as the am I having a boy or a girl test, and they don't realize how accurate it is for other genetic conditions.
You're right. You have that choice of finding out information about the sex chromosomes, that's the X and the Y, and the vast majority of people opt in because they want to know the sex of the baby. But what I'll explain to patients is sometimes, there are girls in this world who have just one X chromosome, and this test would pick it up if that should be the case. And there are boys in this world who, instead of having just one X and one Y, have an X or two X's and a Y, and this test will pick that up as well. So when you're asking to find out about the sex chromosomes, you might actually find out about a sex chromosome abnormality as well, which is useful, but sometimes that's not what patients are looking to find out.
Right.
And so again, it requires a conversation.
And the interesting thing is, the screening tests we do for aneuploidy, so whether it's this blood test or whether it's the nuchal translucency and serum hormone levels or a combination, they're done early in pregnancy. I mean, this blood test can be done as early as 9 or 10 weeks. And then the ultrasound is generally around, 12 weeks. And so you get all this information early, whereas people always thought, oh, I'm going to wait till, I do the anatomy ultrasound at 20 weeks and see if the baby looks normal. And what we've found over the years is these earlier tests are so much better than looking at ultrasound at about 20 weeks, meaning so many babies who have genetic abnormalities will look normal at the 20-week ultrasound. And also on the flip side, a lot of these findings that are suggestive of aneuploidy on ultrasound at 20 weeks are just false, like they're false positives. A lot of quote unquote normal people have that as well. And so if you want to get accurate screening, you're better off doing it early, not late, which is unusual for a lot of conditions.
Yeah, I mean, it's great. That's something that's changed over the years, is that just if you we're getting so much done at the very beginning of the pregnancy, and that's very useful as you go forward, right? So that let's say you do your screening test and you find out that you have good results, you feel good about it. Then if you have a what we call a soft marker on the ultrasound, something that can increase your chances that this baby might have Down syndrome. You've already done the test. You're already better armed or better well equipped to face that news because you already know the chances are pretty low.
Right.
So that's been great to bring all of that into the first or second, visit essentially in the pregnancy.
Pregnant patients decide if they're going to do this screening or not. And then the other option is an invasive test, right? And we say invasive because instead of, doing an ultrasound, which we don't consider invasive, the probe touches the body, but doesn't it's not invasive in that sense. Or a blood test, it's a needle going into the arm. So you could call that invasive if you wanted to, but it's really just a blood draw that people are used to. But when we talk about invasive tests for pregnancy, we're talking about taking a needle and putting it into the pregnancy, right? For a CVS into the placenta and for an amniocentesis into the amniotic fluid around a baby. And that either goes, through the mother's belly, or sometimes for a CVS, you can do it vaginally through the cervix. But those are invasive tests, but they're also diagnostic. So explain the difference between a screening test and a diagnostic test.
Okay, so I think just had you described it earlier, when you're actually going in and either taking cells from the placenta, like in a CVS, or if you're taking cells from the amniotic fluid in an amniocentesis, you're directly testing the patient who is the fetus. And it's just like if you or I were to go and get a blood test and they would tell us the answer, what they found in the pregnancy. So those are the diagnostic tests. It's like the fetus is the patient and you get a sample from the fetus and you get your results. And there's no further testing to be done generally. That is the result. That is the DNA of that fetus.
Right. So why
Whereas
wouldn't someone do that? It's obviously more accurate because it's 100% yes or no. You get a yes or no answer. It's not, screening. It's not these numbers. It's not complicated. Why wouldn't everybody do an invasive test, a diagnostic test during pregnancy?
good question. I think generally it does these procedures do pose a small but real there is a small risk of inducing a miscarriage when you do the procedure. So it's very frightening and it can be a little bit painful. Most people have never had a needle even just put through the skin of their abdomen. So it's an unusual feeling. Sometimes you get a severe cramp, like a menstrual cramp, and so even just the pain is frightening, and the thought of potentially doing anything harmful to this highly desired, highly loved pregnancy is really frightening. So I think it's extremely scary for most patients.
What's the magnitude of that risk? Meaning there is a risk of miscarriage, but what are the numbers we're talking about approximately?
Approximately, the risk for CVS or amniocentesis is about 1 in 500 risk of miscarriage. What makes it hard is that you can never do a study and see, well, what would have happened to these pregnancies that had a miscarriage had you not done a procedure? So there's always a baseline risk of miscarriage. If you don't do any procedure on a pregnancy, some patients will have a miscarriage. And it's actually more likely if there's a genetic abnormality that there will be a miscarriage. So it's very hard. We have numbers based on studies, but we use about 1 in 500 to counsel patients. But the way I look at that number, I know that some of those miscarriages that are in these studies, it might have happened even without a procedure. So it's very hard to get that exact risk.
Right. It's hard. And people say, what's your risk? What's your risk? And, it's hard to sort of differentiate between, centers or people. I think people who do these procedures probably have the same risk because it's more related to the uterus and the placenta and the baby than it is, the actual technique of the procedures. I mean, obviously we do it sterilely and we, clean the belly and we wear gloves and there's, but everyone does the same thing pretty much. And what I tell people is, as you said, we can't find out exactly what the risk of miscarriage is because the only way to do that is literally take 2,000 women, divide them in half randomly, and just do an amnio on 1,000 of them and do nothing on the other 1,000 and see who miscarries more. I mean, that's never going to happen. So what ends up happening is, you look at the data and there's math and there's all this, complex equations and that gets done. And ultimately everyone falls out on some number less than 1%. Right? Whether it's 1 in 200, 1 in 500, 1 in 800, but it's a number that's less than 1%. And so people have to decide, they're in a situation when making this decision where it's so interesting because people grapple with this so much and they have so much angst over this decision. But no matter what they do, 99+% of the time, it's going to work out fine. Meaning
Right.
if they don't do an invasive test, 99+% of the time, they're not going to miscarry and their baby won't have a genetic condition and they're good. And if they do an invasive test, 99+% of the time, they're not going to miscarry and their baby's not going to have a genetic condition. Unless, of course, the screening test said the risk was much higher, then that's something different. And so
Right.
it's generally not the biggest decision people are going to have to make in their lives or the life of their child, but it does get a lot of attention and it gets a lot of anxiety and concern because that's just what happens during pregnancy. But I do agree that most people, if they're choosing not to do an invasive test, it's because they're like, well, why would I take risk when everything seems to be going fine? I just, enough is enough. I don't need to do that. And it's much more of a personality decision. People who want all the information humanly possible are going to do an invasive test. And people who are like, listen, we've done enough. Everything looks good. I don't need you to stick a long needle in my belly to, to prove that to me. And they move on. And I think both of those are fine when the screening tests were normal. Because again, there is a very low risk. When the screening tests are not normal and there's a much higher risk, I think most people will move on to invasive testing unless they really didn't want the screening test in the first place and it was sort of just done. And they're like, no, I don't need to know this information. I probably wouldn't have done the screening test if I really understood what I was screening for.
Yeah, it's a very hard moment, but in the end, after talking to patients, you realize the hardest part of going through the invasive test is really just waiting for those results. That's the hardest part. Like
Right.
once it's done, most patients will say, "I'm fine." I would rate my pain as a 0. That was really pretty good, And so the hardest part is just the anticipation and waiting for the results.
Right. And this was all, sort of known for a while. And sort of when you trained and I trained, this was the conversations we would have with people. And you could sort of give them the risk of Down syndrome and, sort of, maybe weigh it against the risk of the procedure and, come to some conclusion. And then, as you know, this idea of testing for microdeletions came out, this
Yes.
microarray. And that put, I don't want to say a wrench because it's not a bad thing, but it definitely made this conversation a little more complicated from a genetic standpoint. So can you explain what exactly are these microdeletions or microarray testing that's available for an amniocentesis or a CVS test?
When you do an amniocentesis, or if you do CDS and you send the sample to the lab, they will pop open the cells, get the DNA, and look at the DNA, and they'll look to see if you have two of each chromosome, which is what would be expected, adding up to 46, and that's what's called a karyotype, or just checking the chromosomes. When you do a microarray, you're taking a magnifying glass down on each chromosome, like magnifying it much more and looking to see, is there a small piece of DNA that's missing, or is there a small piece of DNA there that's extra? And they'll look, that's what a microarray test is. And so it's designed not to look at the whole genome at every single piece of every single chromosome, rather selected important segments of each chromosome that are known to be important, where there are certain diseases that are caused by a small piece of DNA that's missing in this very specific location. So it's designed to look only at the specific locations on the different chromosomes, and they look on all of the chromosomes 1, 2, 3, all the way to 22, and the X chromosome and the Y chromosome, and it'll tell us if there's a piece of DNA that's either missing or extra. And the lab tries their best to only look at the areas that are very well understood and where the results can be meaningful to families. Like, this missing piece of DNA causes this specific genetic condition, and now we can tell you about that condition so that you can better understand what's going on with this pregnancy.
Right. And so I think what's hard with this is these conditions that the lab is going to test for, essentially. And it's a little bit over 100, I believe,
Right, right.
possible conditions. Most people have never heard of them, right? These are not common conditions. I think all 100 combined, maybe the likelihood of someone having a baby is less than 1%. But it's not like they're nothing. These are serious conditions. It's not like, oh, your baby's going to be a lefty or a righty. I mean, these are major, problems. And so, that's number one. And number two, since people haven't heard of them, it's hard to wrap their head around what they're screening for. And number two, like Down syndrome and like aneuploidy, these are not things that typically run in families. They're usually new. So again, the fact that someone says, well, I never had a family member with one of these conditions, really doesn't have a huge impact on the likelihood of their baby having one of these conditions. And so I think that that's hard for people, again, to wrap their head around, because this is just a new concept that these can be tested for.
Right. I mean, I feel for the patient, because they didn't walk into your office asking for that, to test for, one of these conditions on the microarray. And then here we are offering them 120 of these conditions that can be tested for. So it's very overwhelming. And I think that our colleagues in the lab are trying to help us by providing tests that will provide useful, meaningful information to parents. But there's just no way to learn about every condition on the microarray before deciding you want or don't want to do that test. You sort of have to just take a overall, yes, I want to learn as much as I can, and I have the stomach for maybe getting a result that may be a little bit uncertain, because whenever you do a microarray, you can get a result that's definitive. You can get a result that says everything's fine. You can get a result that says we found a specific genetic condition. But you can also get a result that's called a variant of uncertain significance, where the lab is telling you, we don't know what this is going to mean for your child. And it's just a question mark. Some people will once I explain that to patients, some people will say, I just don't have the stomach for that. If that's something that you might tell me, I'm not doing this test. Most of the time, you can say, look, we'll get you through it if that should come up. But that is something that is a challenge in I think, most prenatal diagnostic centers, is these uncertain results when you do a microarray.
Right. And as you said, it's not something that some people come and say, okay, I'm going to do all the research. I'm going to, look this up. And you can't. I mean, it's not possible to dive into all 120 of these conditions that you've never heard of and learn enough about them, and what it's going to mean, and do I want to test or not want to test. Ultimately, it's almost just like a leap. Like you said, some people, when they're either in their decision to do an amni or a CVS, or when they're doing it for, let's say, Down syndrome, if they want to do these extra tests, it's really just a simple decision of, do I want to get as much information as possible? Meaning I can figure out if my baby does or does not have these other 120 conditions, which again, not at high risk for, but just do I want to know? At the possibility of maybe getting information that'll totally scare us, but we don't really know what it's going to mean. And some people look at that and say, yeah, I want to know everything I can. And other people look at it and go, oh my God, no, that sounds horrible. And usually people know pretty quickly which one of those two camps they fall into. And they'll
Right.
just say, okay, I'm the first person. I want to know as much as I can. And the second one's like, no, I really don't want any chance of finding something that I'm not going to understand what it means. And then they make a decision. And that's when they're doing the test. But sometimes understanding that this option exists will impact people's decision to do an invasive test in the first place. Meaning someone can get back screening tests for Down syndrome that are perfect and say, your risk of having a baby with Down syndrome is, 1 in 10,000. It's really, really low. You're good. And they'll say, okay, so that means my baby's not going to have a genetic condition. And you'll say, well, no, it just means your baby very, very, very likely won't have Down syndrome, but there's other genetic conditions. They'll say, oh, really? Which ones?
Right.
And
Right.
so, and like, oh, and
Right.
then it's sort of like, well, there are these, we can do an invasive test to find out about these other genetic conditions. They're also rare. It's very unlikely your baby has them, but the only way to know is to do an invasive test. And then you'll say, okay, so on the one hand, you can do the test, take that very small risk of miscarriage and that very small risk of finding something quote unquote uncertain, but you'll get all that information. Or you can choose not to do it and just most likely to be fine, but find out after the baby's born. And again, most people will sort of know in their gut, am I the type of person who would take a little bit of risk? And again, it is a little, less than 1%, a little bit of risk to get as much information as possible about the baby. Or am I not that person? But that's important, again, to have these conversations and to sort of put it in context and not just make the decision as they used to do. Okay, I'm over 35, so I'm getting an amnio or I'm getting a CVS, which is so primitive nowadays to make
Hmm.
your decision
Right.
based on that. But it involves a lot of counseling and a lot of understanding about who am I as a person, like, what kind of things scare me and what kind of things don't scare me. And it's there's more thought than you would think has to go into this.
Yeah. I mean, I think I love that when we talk about these things with patients, we're just sitting in a quiet room and you're not on the telephone and you're not doing anything else but just sitting and talking. And it's very important, I think, for a couple to sit in the room and just look at each other and think, well, do we want this information? We never talked about this before. Would we consider an abortion? And they never actually talked about it out loud before. And it's important to give a couple the moment to just sit there and express themselves and think it through. And sometimes there's no answer that day, but I think that's a beautiful thing that we give a patient the opportunity to just sit there, talk it out, and then guide them based on what's important to them and their most important values. And sometimes the couple is not on the exact same page and they need to work it out before moving forward.
Right. Yeah. Sometimes it brings up some
Yeah.
strife. It's yeah, well, I'll be sitting there and be like, so do you want to do the best part is when you say, do you want to do a CVS? And she says no. And he says yes. I'll be like, well, I
Yeah.
can't, like, sir, I can't do it on you. So
Right, right.
I think, yeah, her
Exactly.
decision is going to, I think, ultimately take first precedent. But it is something that people have to, try to get on the same page. And it's just so important. Advice I give pregnant women about this is, you can either go down the road that, like, close your eyes, your doctor will order some tests or not order some tests, and you're sort of at the mercy of what they order and hope it's all good. And if it's not, you'll deal with it. And some people just find comfort in that. They just take all the decisions out of their, hands. But if you really want to be involved in these decision processes, to have a conversation like, what are we screening for? How are we doing it? Is this what I want? Do I want to do an invasive test? Do I not want to do an invasive test? And to talk about these things in advance so you can only do the test that you want done and make sure you get all the tests you want done on both ends of that spectrum. Because a lot of times people don't think about this, don't talk about this. And again, if everything comes back normal, who cares? But sometimes they really end up in a situation where they did tests that they didn't want to do, or they don't do tests that they did want to do. And I think that
Mhm.
that's unfortunate because there's a lot of ways this can be done for each individual person.
We spoke earlier about changes that I've seen in the field of genetics, and right when I was starting my OBGYN residency, I remember learning about the shift in how we're going to counsel patients, and the American College of Genetics and the American College of OBGYN came out and said we're going to move away from being prescriptive or paternalistic and say, okay, you're over 35, you're going for amnio. Rather, we every woman has some risk of having a baby either with Down syndrome or another genetic abnormality or microarray finding. The risks are different depending on your age, and sometimes it doesn't depend on your age. And so nowadays, what we do is we lay it all out there for the patient to see all these test options are out there. These are the things that are available in 2020. And it's like a menu. Like you can pick whatever you like. They're optional. You don't have to do any of these tests. And so it puts the decision and it gives the decision making to the patient, which is empowering for the patient, but it can sometimes be overwhelming. And sometimes the patients are like, could you just decide for me? And they want to go back to the way it was. But I do like that we at least offer the patient to be part of that decision making process and take them through it.
Wonderful. Well, Tamar, this has been so helpful and insightful, and I'm sure a lot of people listening now understand a lot more than they did. Maybe they have a lot more questions now also than they did before. And we're always happy to take questions if people send them in. We'll try to answer them. And obviously, we're going to, I think, even do one more to talk about carrier screening, which is its own separate topic. A lot of overlapping principles, but still conceptually, it's a little different genetically. But thank you so much for coming on and talking
Sure
about
thing.
this. Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.